Chromium keeps showing up as a blood sugar shortcut, so let's stress test the claim instead of repeating it. The interesting part is not whether chromium can touch insulin biology. It can. The real question is whether that pathway still delivers meaningful glucose or weight results in people, or whether the supplement aisle is selling an old cofactor story as a modern cure, all for insulin resistance.
So is the mechanism itself fake, or is it real biology that just got oversold in supplement ads? What is chromium actually supposed to do inside an insulin-resistant muscle or fat cell?
The classic account is that trivalent chromium helps form Chromodulin, an oligopeptide that can potentiate insulin at the receptor. With better receptor engagement, carbohydrate and lipid handling may improve at the cellular level. That is a coherent physiology story. It also creates a marketing trap, because a cofactor narrative sounds like a drug-sized promise, even when human trial effect sizes stay small, mixed, and easy to exaggerate. Absorption widens the gap between bottle math and biology. Inorganic chromium is often absorbed under 2%, while some organic complexes are more available. Absorbed chromium circulates with plasma proteins, such as transferrin, and leaves mainly in urine. So a bold labeled dose is not a guaranteed tissue dose, and stress-related demand talk is not proof that a capsule will flatten fasting glucose for everyone.
Then who is actually the best fit person if the biology is real but uneven? Someone with metabolic syndrome, someone with PCOS insulin resistance, or the average person chasing a flatter glucose curve from a drugstore bottle?
Before we crown a best fit user, keep the dose boundary honest. Chromium is not a casual candy mineral. A published case linked about 600 micrograms of over-the-counter chromium picolinate daily for 6 weeks with severe kidney injury. That report does not prove every user is harmed, but it ends the idea that megadosing for fat loss is low risk or self-serve.
Staying near study-like doses instead of megadoses. What did the metabolic syndrome trial actually move? Was it HbA1c, lipids, blood pressure, body weight, or mostly noise once placebo entered the picture?
In a 12-week randomized trial, adults with metabolic syndrome took 400 micrograms of chromium picolinate daily. HbA1c fell about 0.68%, HDL cholesterol rose about 4.8 milligrams per deciliter, and systolic pressure declined. After adjustment, HbA1c and systolic pressure still beat placebo, but the leftover edges were modest. The authors said clinically meaningful change may need better dose and duration work before anyone treats this like a first-line tool. In plain terms, useful signal, not a miracle. Product reality belongs beside those numbers. NCCIH notes that store or online supplements can differ from products used in studies, and they may interact with medicines or complicate surgery planning. FDA consumer guidance still treats dietary supplements as products you evaluate for risk, not as approved glucose drugs. A capsule is not a prescription titration, even when the biomarker shift looks tidy on a chart.
Creators also push chromium hard for PCOS insulin resistance. Does mineral research there look stronger than the metabolic syndrome result? Or is it the same modest story with a louder thumbnail and less isolation?
A meta-analysis of mineral supplements in PCOS found pooled reductions in fasting glucose, fasting insulin, and HOMA-IR across randomized trials. That supports an insulin resistance use case better than general wellness browsing. The catch is the pool mixed magnesium, zinc, selenium, and chromium forms, so chromium is not crowned as the sole active piece. Lipid findings were mixed, including a small aggregate HDL dip that should cool absolute claims.
What about the weight loss pitch that still sells so hard? If a program adds fiber, probiotics, and chromium together and the scale moves, can we credit chromium? Or is that the whole lifestyle bundle wearing a mineral costume?
Credit the bundle, not the mineral costume. One 8-week lifestyle program paired diet advice with fiber, probiotics, and chromium and saw several kilograms of loss, but chromium was never isolated. A dairy cow meta-analysis can show production responses to chromium supplementation, which is interesting animal physiology and almost useless for human fat loss claims. If the bottle promises a leaner body as the main win, the human evidence remains thin. Pregnancy and environmental chromium sit in a different lane from a multivitamin sprinkle. A large synthesis linked higher gestational metal exposures, including chromium in some biospecimens, with higher odds of preterm birth and related newborn vulnerability. That is exposure epidemiology, not a green light for high-dose pills, and it is a reason not to freestyle concentrated chromium while pregnant or planning pregnancy. Also, separate chemistry and exposure source before the comments section blends them. Nutritional discussions usually concern trivalent chromium, while hexavalent chromium is the industrial toxicant with a very different hazard profile. Food and ordinary supplement contexts are not the same as occupational hexavalent exposure, and seafood chromium measurements and contamination studies are monitoring signals, not proof you should chase higher pill doses for metabolic health.
If someone with metabolic syndrome still wants a short, clinician-guided trial after hearing all that, how should they judge whether it helped without falling for one-pill drama? And when should they stop and call it a miss?
Keep the decision filter narrow. Chromium can belong in an insulin cofactor story, and selected metabolic syndrome or PCOS-mineral contexts show modest biomarker movement rather than miracle reversals. It is not a reliable weight loss engine, not a one-pill diabetes fix, and not harmless at high doses. If it is used at all, use it as a short measured adjunct beside diet, movement, sleep, and medical care, not as the main therapy holding the whole plan together.